I specialize in clinical pharmacology with a focus on men's health. And the single most underreported cause of erectile dysfunction in men over 60 that I see in my practice is not aging, not testosterone decline, not psychological stress. It is the medications those men are already taking, drugs their own doctors prescribed, drugs they have been told are keeping them healthy. And in many cases, that is true, but no one explained the trade off. Today, I am going to go through 7 of the most commonly prescribed drug classes directly connected to erectile dysfunction in men over 60, explain exactly how each one disrupts the physiological process required for an erection, and give you information you can bring back to your own physician. Not to stop your medications, never do that unilaterally, but to have an informed conversation about what is happening in your body and what alternatives may exist. If you are over 60, take at least one daily prescription medication, and your sex life has changed since starting it, this video was made for you. Before I go further, let me be direct. I see men in their early 60s in my practice who believe the decline they are experiencing is what aging does. They accepted it. And in a significant portion of those cases, when we reviewed their full medication list together, the answer was sitting right there in the pharmacy bag. 7 in 10 men over 65 take at least 2 prescription drugs daily, according to CDC prescribing data. The intersection of polypharmacy and sexual function is almost never discussed in a standard office visit. I am going to discuss it here. Stay with me through all 7, because the one that explains your situation may not be the first one I cover. To understand why medications cause erectile dysfunction, you need to understand what an erection actually requires. 3 pillars, all functioning simultaneously: adequate free testosterone in the blood, intact dopaminergic signaling from brain to pelvic nerves, and sufficient arterial pressure and tone to fill the penile tissue. A medication that undermines any one of these, especially against a baseline of age-related decline that has already narrowed the margin, can tip the entire system into dysfunction. This is not a theory. The Journal of Sexual Medicine published a review in 2022 documenting iatrogenic erectile dysfunction, that is, erectile dysfunction caused by prescribed treatment, as the primary etiology in approximately 25% of cases in men over 60. 1 in 4. And in many of those cases, the medication was not adjusted because the prescribing physician either did not ask about sexual function or accepted the patient's silence on the subject as satisfaction. Let me go through each class, mechanism by mechanism. The first is beta blockers. Among the most prescribed drugs in the world, used for high blood pressure, heart failure, and arrhythmia, they work by blunting the sympathetic nervous system response, lowering heart rate and blood pressure by blocking beta adrenergic receptors. The problem for erectile function is that this same blunting affects peripheral vascular tone. The smooth muscle in the penile arteries requires adrenergic signaling to relax and allow inflow during arousal. Beta blockers reduce that signaling. They also reduce central dopaminergic drive, dulling neurological arousal before a man notices he is less interested. Studies comparing men on common beta blockers against controls show erectile dysfunction rates 2 to 3 times higher in the beta blocker group, adjusted for age. Not all beta blockers affect function equally. Older, non-selective types are the worst offenders. If you are on a beta blocker and experiencing ED, this conversation is worth having with your cardiologist. The second drug class is thiazide diuretics. Hydrochlorothiazide is the most commonly prescribed. These reduce blood pressure by decreasing sodium and water reabsorption in the kidney, reducing blood volume and therefore cardiac output. The mechanism of ED here is twofold. First, the reduction in blood pressure itself, while beneficial for cardiovascular risk, can cross a threshold where penile perfusion pressure is no longer sufficient for full tumescence. An erection requires active blood pressure, not lowered blood pressure. Second, thiazides reduce zinc levels over time through enhanced urinary excretion, and zinc is a cofactor in testosterone synthesis. A 2019 study in the International Journal of Impotence Research found that men on long-term thiazide therapy had significantly lower free testosterone than age-matched controls not on antihypertensives. The combination of reduced perfusion pressure and reduced androgenic support creates a compounding deficit. The third is antidepressants, specifically SSRIs and SNRIs. Sertraline, escitalopram, venlafaxine, duloxetine. These are increasingly prescribed in men over 60, not only for depression, but for anxiety, pain syndromes, and sleep disturbances. The mechanism is direct. SSRIs elevate serotonin, and elevated serotonin suppresses dopaminergic pathways. Dopamine is the neurotransmitter of desire. Without dopamine activation, the arousal signal that initiates the erection cascade is weakened before it ever reaches the pelvic nerves. SSRIs also directly suppress nitric oxide synthase activity in endothelial tissue. Studies show sexual dysfunction in 40 to 70% of patients on SSRIs, depending on the agent. Men over 60 are particularly vulnerable because they already have reduced dopaminergic reserve. Adding an SSRI to an aging dopaminergic system produces dysfunction that appears indistinguishable from primary erectile dysfunction. Bupropion, a dopaminergic antidepressant, has a dramatically lower rate of sexual side effects and, in some cases, improves function. If your sexual function changed after starting an SSRI, that timing is not coincidence. The fourth is 5-alpha reductase inhibitors, finasteride and dutasteride. These are prescribed for benign prostatic hyperplasia and for male pattern hair loss. They work by blocking the enzyme 5-alpha reductase, which converts testosterone into dihydrotestosterone, or DHT. DHT is a potent androgen, more active than testosterone at androgen receptors. Blocking its production reduces prostate size and slows hair loss. It also removes a primary androgenic stimulus from penile tissue, genital sensation pathways, and brain regions involved in sexual motivation. The FDA added a label warning about persistent sexual side effects in 2012 after accumulating reports of ED, reduced libido, and ejaculatory dysfunction, a syndrome now documented in the literature as post-finasteride syndrome. If you are taking finasteride or dutasteride for your prostate or your hairline, and you notice changes in erectile function, penile sensitivity, or ejaculation, this is a direct pharmacological connection. The fifth is opioid analgesics, prescribed with increasing frequency in men over 60 for chronic pain, arthritis, back pain, post-surgical management, neuropathy. The sexual pharmacology of opioids is poorly communicated. Opioid receptors are expressed throughout the hypothalamic pituitary axis, and chronic use suppresses GnRH, gonadotropin-releasing hormone, the top of the hormonal cascade. No GnRH means reduced LH. Reduced LH means the testes receive no stimulus to produce testosterone. The result is opioid-induced androgen deficiency, a recognized clinical syndrome with its own diagnostic criteria. Studies show testosterone levels in men on long-term opioid therapy equivalent to late-stage hypogonadism in the majority of patients. Men in chronic pain already face psychological and vascular stressors affecting sexual function. Layering pharmacological testosterone suppression on top creates a condition almost impossible to address without first addressing the opioid burden. The sixth is H2 blockers and proton pump inhibitors at high doses. Cimetidine, an older H2 blocker still prescribed in some populations, has documented anti-androgenic activity. It competitively binds androgen receptors and reduces testosterone bioavailability. Proton pump inhibitors like omeprazole and pantoprazole, taken at high doses for extended periods, have been associated in recent epidemiological data, including a 2023 analysis in Alimentary Pharmacology and Therapeutics with elevated prolactin levels. Prolactin is a hormone that, when elevated above its normal range in men, directly suppresses LH pulsatility and testosterone production. It also reduces dopaminergic drive, because dopamine is the primary inhibitory regulator of prolactin. High prolactin means low dopamine, low testosterone, and reduced desire and erectile response simultaneously. Many men over 60 take a PPI every day, often indefinitely, without ever having their prolactin level checked. If you are on a long-term PPI and have not had prolactin measured, ask your doctor. The seventh is spironolactone, a potassium-sparing diuretic prescribed for heart failure, resistant hypertension, and in some cases, liver disease. Spironolactone is a direct androgen receptor antagonist. It was originally developed as an anti-androgen. It blocks testosterone from binding to its own receptor in target tissues, including penile tissue, brain, and muscle. The therapeutic benefit in heart failure is real. The androgenic cost is also real and often not mentioned. Men on spironolactone experience erectile dysfunction, reduced libido, and gynecomastia, breast tissue development, at rates substantially higher than those on other antihypertensives. Newer mineralocorticoid receptor antagonists like eplerenone produce similar cardiac benefit with far less androgenic disruption. If you are on spironolactone and your sexual function changed after starting it, this is the mechanism. An alternative exists worth discussing with your cardiologist. If you found value in this breakdown, subscribe to this channel and give this video a like, because the information I just went through is almost never delivered in the 15 minutes a man gets with his physician. Men deserve to understand the pharmacological trade-offs of the drugs they take every day. Help this kind of content reach the men who need it. Before I move into what you can actually do with this information, how to have this conversation with your doctor, and what physiological support exists while you navigate a medication review, I need to be honest about something I learned after years of working in this field. For most of my career, I approached hormonal and erectile support through two levers: medication adjustment and behavioral protocol. Diet, exercise, sleep, stress reduction. I was skeptical of nutritional supplementation in this context. My training emphasized clinical trial evidence, and most supplement research had not reached the methodological threshold I required. That was a reasonable position, and I am not embarrassed to have held it. But I am also honest about when my clinical observations required me to revise it. The gap I kept running into was this: men who reduced or adjusted the offending medication under their physician's supervision and adopted the behavioral protocol I outlined still showed incomplete recovery of hormonal balance, particularly men over 62 who had been on hormonal disrupting medications for several years. The issue was not motivation or adherence. The issue was that the hormonal axis had been suppressed long enough that the biological machinery was slow to restart. The hypothalamic pituitary testicular axis is not a light switch. It takes time to recover. And in men with reduced reserve, habit changes alone were not closing the gap within a clinically meaningful timeline. That gap is what led me to research formulations I had previously dismissed. What I found, and subsequently began testing with patients, was a combination built around two mechanisms directly relevant to what these medications disrupt. The first is fenugreek, an aromatase inhibitor. Aromatase is the enzyme that converts testosterone into estrogen. In men whose testosterone was already suppressed by medication, elevated aromatase activity was compounding the deficit by converting what little testosterone was being produced into estrogen instead. Fenugreek inhibits aromatase, which means more of the testosterone being produced remains bioavailable rather than being shunted toward estrogen. The second is Tribulus terrestris, a plant that stimulates luteinizing hormone, the signal from the pituitary that tells the testes to produce testosterone. In men whose LH was blunted by opioids, spironolactone, or prolactin elevation, Tribulus helped reestablish that upstream signal. Together, these two mechanisms address the problem from both ends, preserving what is produced and stimulating production itself. What I observed clinically was not a dramatic overnight change. In men between 62 and 70, navigating medication adjustment and the behavioral protocol, the combination produced measurable improvement in reported energy, libido, and erectile response over 8 to 10 weeks, consistently enough across different patient profiles that I kept it in the protocol. I verified the composition and purity documentation before recommending it. It is not a medication. It does not replace the medication review I am about to describe. But for men dealing with the hormonal suppression these drugs produce, it provided the biochemical support the axis needed while recovering. I have placed a link in the video description for anyone who wants to review the composition at their own pace. Now, here is what to do with everything I have told you. The most important thing you can do after watching this video is make a list of every medication you take and bring it to your next appointment with a specific question. Which of these have documented sexual side effects? And are there alternatives with a better profile? That is not a confrontational question. It is an informed one. Most prescribing physicians will welcome it. Do not walk in and say, "My medication is causing ED." Walk in and say, "I have been reading about the sexual side effects of some of the classes I am on, and I would like to understand whether switching to a different agent within the same class or adjusting the dose is clinically appropriate for my situation." That framing positions you as a collaborator, not a patient refusing treatment. For beta blockers, ask whether a calcium channel blocker like amlodipine might achieve equivalent blood pressure control with a better sexual function profile. Calcium channel blockers have among the lowest rates of sexual side effects of any antihypertensive class. For SSRIs, ask whether bupropion is appropriate or whether a lower dose trial is warranted. For finasteride, alpha blockers like tamsulosin manage BPH without androgenic suppression. For long-term PPI use, ask whether on-demand dosing or famotidine might be appropriate. Many men are on daily PPIs for a condition that resolved years ago. The biochemical environment these drugs create does not have to be permanent. The hormonal axis has adaptive capacity. With the right medication review, behavioral support, and targeted physiological reinforcement, men in their 60s consistently recover meaningful function. The ones who do it most effectively are those who understood the mechanism clearly enough to have a precise conversation with their physician. You now have that understanding. Let me put this in the broader context that I think every man over 60 deserves to understand. The sexual function decline men experience in their 60s is almost universally attributed, by the men themselves and by many clinicians, to aging. Aging is real. The gradual testosterone decline beginning in the early 40s, reduced penile tissue elasticity, slower neural conduction, these are physiological facts. But iatrogenic suppression is pharmacologically distinct from natural decline. Natural decline is slow and incremental. Iatrogenic suppression has a timestamp. It begins when the drug was started. That means it also has a potential reversal. The body does not forget how to produce testosterone because a medication blocked the signal for 2 years. It needs the pathway reopened. What research on older male cohorts consistently shows is that hormonal recovery after the removal of suppressive medications is real, but it is time dependent. The longer the suppression, the slower the recovery. A man who has been on spironolactone for 10 years will not recover hormonal function in 4 weeks. But a man who is actively managing that recovery with appropriate medication adjustment, behavioral support, and targeted physiological supplementation has a meaningfully better trajectory than one who was simply told that what he is experiencing is normal for his age. Research tracking hormonal recovery in men who discontinued suppressive medications shows those who combined medication adjustment with structured behavioral protocol recovered testosterone function at roughly twice the rate of those relying on withdrawal alone. Passive recovery is possible. Active management is measurably superior. What no data set captures fully is the impact of a man in his 60s recognizing that what he thought was permanent decline was actually addressable. The men in my practice who reached that recognition did not just recover function, they recovered agency over their own physiology. Men who understand mechanisms stay engaged with their health. That engagement compounds. Let me close with what I want you to take from today. 7 drug classes: beta blockers, thiazide diuretics, SSRIs, 5 alpha reductase inhibitors, opioids, H2 blockers and PPIs at chronic doses, and spironolactone. Each disrupts the hormonal, neurological, or vascular foundation required for erectile function through a specific documented mechanism. These are not rare side effects found in 1% of users. They are predictable pharmacological consequences that occur with clinically meaningful frequency in men over 60, whose margin for compensating for that disruption is already reduced by natural aging. Tell me in the comments, are you currently on any of these drug classes? And did your doctor ever discuss the sexual function implications with you when the prescription was written? I ask because I want to understand how often this conversation is actually happening and how often men are being left to figure it out on their own. The Leydig cells in your testes, the cells responsible for testosterone production, have a functional reserve that is real but finite. Chronic pharmacological suppression of the signals those cells depend on gradually reduces that reserve. Recovery is possible, but the window narrows with duration of suppression. The men who act on this information, who bring it to their physician, who request a medication review, who actively support their hormonal recovery pathway, consistently do better than those who wait for a more convenient time to address it. The nutritional support I described earlier, built around fenugreek and tribulus, targeting the aromatase pathway and the luteinizing hormone signal, is listed in the description below. Access it, verify the composition, and evaluate whether it belongs in your protocol. That decision is yours to make calmly and at your own pace. A doctor once told me that the difference between patients who recover and those who don't is rarely the severity of the problem. It is almost always whether they understood it clearly enough to act. You now understand it.